Guys, you all set? All right. So this is Dr. Lounsbury. She's a professor of emergency medicine at UVA, and she's part of and I think I've talked to you guys about this before, a guest lecture series that we have put together as a collaboration between all of the Virginia PM programs. So Dr. Webb had gone and given a presentation up at UVA. Dr. Sapp is going to be doing so over at Roanoke Memorial, and then at some point, if you guys ever stop causing trouble for me, my plan is to go out to Riverside and give a presentation out there. And in return, we get to listen to Dr. Lounsbury and learn about something that I definitely do not have the ability to educate on.
Yeah, that's
so I'm
cool.
looking forward to
That's cool. That's a general reaction that I get when I talk about this. So hi, my name's Heather. I'm one of the assistant professors up at UVA. Just a little bit about myself and why this topic is really important to me, besides what's probably the obvious right now. So I'm from Phoenix, Arizona originally. I went to college in Nebraska, went back to Arizona for med school, and then matched at UVA for residency, and I've been there ever since. Did an education fellowship there, and then have been on faculty. This is not something that was ever on my radar up until probably 2 years ago when I had my daughter, and realized that this is like a big area of medicine that I actually don't know anything about. And it's something that I think impacts a lot more patients than you realize. And you can do a gargantuan amount of harm to that patient and their relationship with their child if you don't know what you're doing. And so it's some pretty basic stuff today. I'm not going to try to talk to you about all the hormones that control breastfeeding. And I'm not trying to teach you all how to breastfeed because many of you will never do so in your lives. But I do think, again, a basic knowledge is really important and can make just a world of difference. And it's not something that I ever learned about in med school or in residency. And that's the general sense that I get from everybody that I talk about. So I'm going to convince you that you care about this, you should care about this for your patients, and that you can, again, with some really basic steps, make a really big difference in someone's life. So as we were saying, ER docs have weird senses of humor. So this isn't like, let's learn about breastfeeding. This is so great. This is how you can absolutely kill someone's breastfeeding relationship in the ED by your seemingly meaningless actions or advice. So number one way to kill it is have no idea what you're talking about to begin with. What is normal? What's not normal? I think a lot of people, my general sense of breastfeeding before I did it was, it's like a lifestyle choice. Like I'm vegan too. And that's my choice. And I can, medicine can kind of do whatever it wants and I have to work around it. But breastfeeding is actually like a medical thing. It's a physiological thing and can cause a lot of problems if it's done incorrectly. And so if you don't know what normal is, one, don't opine about what it is that a patient is doing. You can have your opinions about my diet all you want, but you can't actually have uneducated opinions about breastfeeding. So I'm going to try to give some very, very, very basics of how breastfeeding works and what would be normal. So anatomy, this is so stupid, but something that I did not even realize until I started doing this is when there's a lot of talk about external anatomy. So when someone told me to get an electric pump, I had to measure my nipple to size the flange. It's shocking how many physicians measure the whole areolar complex. That's wrong, okay? Your nipple is just the tiny little part in the middle. That's where all of the milk is gonna come out from, is from the nipple. So nipple, areola, and then breast tissue. There's a bunch of lymphatics in there. The actual internal anatomy is really interesting with the lobules where the milk is actually made, and then ducts that kind of coalesce into the nipple. And you'll have 6 to 10 ducts that empty out of the nipple. So 6 to 10 streams. I have a picture of that in a minute. But the internal anatomy is really not your problem. It's not something that you need to know very much about. And it's significantly more complicated than that. But nipple, areola, breast tissue, etc. So how the heck does it work? At the beginning, breastfeeding or lactation, lactogenesis is automatic. So if you are pregnant, you have a placenta, you deliver that placenta, your body will start making milk. whether you really want it to or not. And there may be reasons that you don't want it to. But it's all hormonal at that point. So it's your progesterone tanks after you deliver your placenta, your prolactin and oxytocin start increasing, and those kind of drive that beginning lactogenesis. Now, like it says here, the first thing that you make doesn't really look like milk at all. It's something called colostrum, which is this kind of thicker, usually yellow to orange colored stuff. That's very, very small volume, and we'll learn about why that is in just a second. But that's the stuff that will be coming out. A lot of people will start leaking this even before they deliver, or they can hand express it before they deliver. So just like I told my 13-year-old stepson when I was trying to explain breastfeeding to him, I was like, it's kind of like milking a cow. You just squeeze it and something comes out. So if you squeeze it, this colostrum will come out before you even deliver the baby. And you can save it and give it to them later if you want to. But that starts before delivery. And then at delivery, for the first 30 to 50 hours of baby's life, this is what you're making. Colostrum is super rich in IgA, really very nutrient dense, just very low volume. And again, we'll talk about why that is in a second. Then your milk comes in, which is what people will talk about on day 2 to maybe 3. Normal can be up to day 10, which should be delayed, but milk comes in, and then basically the supply and demand cycle takes over. So hormones are much less important at this point, and it's all about how many times do you try to remove milk from the breast. That will increase how much the breast actually supplies. So totally supply demand dependent. And so what that translates to, again, thinking about normal, like what is this person experiencing on a day-to-day basis? They're removing milk every 2 to maybe 3 hours, 24 hours a day, 7 days a week. No, you can't just not do it. Otherwise, bad things happen to you. And so this will be important for patients that are just in your ER, maybe for something else. They can't just wait. They can't just not do it. Doing that Q 2 to 3 hours for the first 6 to 12 weeks is really important. And then some people can start to space this out a little bit. We'll just touch on that. But at the beginning, it's super important. And this is, again, all night long, all day long, no breaks. And if the baby's not latching and removing, then you're going to have another plan for how you're going to do that. Thought there was another thing I was going to say there, but I guess not. Oh, vocabulary. Good. I'm glad I put this slide in. On the last slide, I talked about Q 2 to 3 hour removals. So it's not emptying. This is a really common misnomer. You can't actually empty a breast of milk. There's always going to be some there because it's constantly getting made. So don't tell people oh, pump to empty, or, feed the baby until you feel empty, because you're just confusing them a little bit. Well, milk is still coming out, so I'm just going to keep going. And then they were pumping for an hour and their nipple gets torn and it's a whole other thing. So that really sucks. Don't do that. But so pump for 15 minutes or so is usually kind of average for people, 15 to 30 minutes. But so removals, not emptying, just some general vocabulary. So if people say stuff, you're not going to look at them cross-eyed, what in the world are you talking about? EBF, exclusively breastfed. Direct fed or a direct feed is when baby actually latches to the breast to eat. If they're taking a bottle, it can still be breast milk that mom expressed, but it's EBM, express breast milk. Some people, for a multitude of reasons, exclusively pump. They don't actually let baby latch at all. There's no direct contact with the breast. They just use a breast pump and then feed the baby that milk later. A lot of women will talk about a letdown, or you can ask, particularly after lactogenesis 2 starts, you can talk to them about a letdown. This is a sensation that some women will get when those ducts kind of contract, or the lobules contract to push the milk into the duct. It's kind of like a water balloon filling up feeling. It's kind of a tingly feeling. It doesn't really hurt, but some women will be like, holy crap, what is happening to me? And they'll come in and try to ask you about it. So weird sensation is usually a letdown sensation. Not all women will feel this. It happens to everybody. That's how the milk gets out of the lobule, but not everybody has this sensation. I was talking earlier about how many removals you do in a 24-hour period. So again, at the beginning, 8 to 12 removals is kind of minimum or standard. After you kind of set your supply, you regulate your supply, which takes about 6 weeks, you can kind of start fiddling with that a little bit. And it's entirely based on what your personal storage capacity is. So how much milk can a breast hold? This is different for everybody. It has actually nothing to do with the size of their breast. So you can't estimate like, oh, you're a D cup, you're going to hold more than someone who's a B cup. It's not related at all. So the only way to figure this out is some trial and error. So if I were you as the ER person, I wouldn't get involved in trying to tell them how many times in 24 hours they should pump. They need to figure that out kind of on their own. The only thing you can say is at the beginning, 8 minimum and up to 12 within 24 hours. If they're not doing that when baby is 2 weeks old, they're never going to get to full supply and their supply is going to drop off and tank. And there may be reasons for that to be okay. But after 6 weeks, don't weigh in on how much they pump. Just let them do whatever they want to do. If they think their supply is dropping, the answer is more demand. So you can say, oh, you think your supply is cut in half, maybe you should pump more. Back away. That's all you got to say. Don't like try to make specific recommendations. And so their magic number is how many removals in 24 hours they need to maintain that supply. And again, depends entirely on how much a breast can hold. So how you figure out storage capacity, just if you care, is you pump like first thing in the morning. So your longest stretch. So if you don't feed baby or don't pump all night long, which most women cannot do, but in the morning you pump how much is the most amount of milk you've ever gotten out of a breast. Is it you only get 2 ounces? Is it 10 ounces? It's really variable what people will get, but that's how you determine what your storage capacity is. So if you're direct feeding, I don't know, like because baby can get out milk much faster than a pump can, and you just have no idea short of doing a weighted feed where you weigh the baby after you feed them. So again, this is just some vocabulary and some basics so you guys can talk to people about it. Latching is getting the baby to actually like, suction on to the nipple. This is an example of a good latch. So the lips are kind of flipped out on both sides, mouth is open really wide. I don't have an internal picture, but there shouldn't be any contact at all with baby's lips and the nipple itself. So the nipple is kind of like free floating in the mouth, similar to the correct fit flange in there. If you are having pain with breastfeeding, direct breastfeeding, it's because your nipple is actually getting like pulled on and baby isn't latching correctly for whatever reason. So latch should be painless, ideally, as should pumping. So when I gave this lecture to the UVA folks, they wanted me to talk a little bit about flange fitting. This is not your problem to troubleshoot. There's like a lot of controversy about exactly how tight that flange should be around the nipple. And it's just like, if you don't have personal experience doing it, and even if you do, probably don't try to recommend anything to anybody other than that they see a lactation consultant who can help them figure this out. But just so you guys know, again, talking about that flange, the nipple is supposed to be not rubbing against the wall. If there's friction there, you're going to get nipple tears and trauma, and it hurts and it sucks. So volumes, I talked about at the very beginning. So day 1, you're just making this colostrum material. Baby's stomach is like 1 to 1.5 teaspoons of volume. So it's teeny little volumes, just drops really. And that's why they're nursing so frequently early on. And really they say, let baby nurse whenever they're giving you a cue that they want to. If they're crying, put them to the breast. If they're wiggling around, put them to the breast. If they're rooting, put them to the breast. If they're chomping their lips, just do it. When they're awake, just put them on there and see what happens, basically, is what we tell people. You can't feed the baby too much. And again, just really little bits are coming out. And this is where that supply and demand becomes really important. If you don't allow baby to try to amp your supply up, you're going to get stuck down at these low volumes, which is a problem. But it pretty rapidly increases. So teaspoons up to an ounce a couple days later. And then full, like after day 10 to 14 of life, they'll take an ounce to 1.25 ounces an hour for the entire rest of the time that they breastfeed. So this is quite different than formula babies where you increase the volume as the baby gets bigger. This is an ounce an hour for the entire first year of their life. So that doesn't have to change, and it really shouldn't change. So that means full supply for mom, if you're pumping, is 24 to 30 ounces in a 24-hour period. So however many times you have to remove milk to get that amount, that's full supply. Same number of poop and pee diapers as your day of life for the first 5 days or so, then things kind of can do whatever they want. Breastfed baby poops are like half of the posts on this lactation group I follow on Facebook. Like, is this poop normal? Probably, as long as there's not blood in it, the poop's fine. Green, yellow, I don't care. Frothy, liquid, solid, whatever. If there's not blood, just let them poop. And normal for breastfed babies, especially after like 6 weeks of life, to poop like once a week, once every 10 days. So you're not really constipated as a breastfed baby. You just will have a big blowout eventually, like day 10. And as long as it's not, you know, a rabbit pebble, which it never is, it's fine. So you might get a lot of questions about that from moms as well. Baby hasn't pooped in 2 days. Just put him in a nice outfit. It'll be okay. They'll definitely poop as soon as you dress them up. So don't bring a spare and go outside. And they're going to
social scenario, and
blow up
undoubtedly you will.
Yeah,
You will get a
it will happen.
Yeah.
It will happen. But then some babies poop every single time they nurse. So like that's what my daughter did. I swear to God, like literally 10 poop diapers every single freaking day. And I cloth diapers. So this is like a lot, a lot of poop. So a very wide range of normal. This is my little breastfed nugget, Clara. When she was 6 months old, she's a chunk. Again, big cloth diaper on that booty. Her booty was not that big, but it's cute anyway. So what's normal weight gain? This is really where the money is at in terms of helping mom or parent figure out if baby is getting enough milk. It's all about the weight gain, because again, if you're direct feeding, you don't actually know how many ounces the kid is getting each time. Kids will latch onto the breast for a lot of reasons that are not just eating. And so people get really, really, really concerned about weight gain in their kids. So there are very well-established guidelines for this. 0 to 4 months, they're gaining quite a bit. So up to 8 ounces a week, so an ounce a day. 4 to 6 months, it really starts to slow down. And then 6 to 12 months, again, it slows down even further. As long as they are gaining weight, they are getting enough to eat. I don't care behaviorally what you see happening. If they are eating and gaining this amount of weight, then you are fine. All the other stuff is normal newborn behavior. And you just, psychologically, it can be really difficult, but physiologically, they are fine. And I'll talk about that again in a second. In the first couple of days, babies can lose a fair amount of weight. That's normal. They will take up to 10% loss of birth weight in a formula or breastfed baby. Beyond that, then they start to think about supplementing the baby, or why is baby losing so much weight? There's a little bit of wiggle room with that. Like if mom had a 40-hour labor that ended up with an emergency C-section and got 8 liters of IV fluids over that 40 hours, baby puffed up too, and so they may end up losing more weight than 10%. It's probably just all this extra fluid that they had, but 10% is kind of the marker that I think as an ER person you should know about. If baby is losing more than 10%, that this needs to be a discussion with their pediatrician or with the inpatient team about watching this kid and making sure they start going in the right direction. They should regain their birth weight by 2 weeks. So they might nadir a couple days in, but by 2 weeks, they should be back up to birth weight. If it's taking longer than that, then that needs to be investigated, whether it's baby isn't latching well, they're not understanding feeding cues, there's some metabolic thing going on with the baby, there's some GI issue going on with the baby. That needs to just be at least monitored by their pediatrician. Could be an outpatient process, but okay. So now that we know kind of basic stuff, Got to feed the baby, got to feed the baby regularly. What happens kind of, or what are some complications of breastfeeding that you guys will definitely see in your career? And by mismanaging it can really, again, negatively affect the mom and the baby. So first things first, engorgement, commonly sort of conflated with mastitis potentially. This is when your milk comes in. So in that first 2 to 5 days of life, when the lactogenesis 2 starts and you really start getting milk and not colostrum, your boobs can turn into rocks. Okay, they are really swollen, they're really tight, they're really painful, they can get a little bit red. It can, for some women, be an overwhelming experience. And people are convinced like, oh, your milk is coming in, you got to get that milk out, you got to pump, 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 right? Keep pumping, and we got to get all this out. And yeah, you are like, oh my God, you are setting this person up for an absolute nightmare of a breastfeeding relationship if you tell them to start pumping this early on. Don't do it. Okay. Most of what's going on in the breast tissue is inflammation and edema. It's not milk that's making their boobs grow 3 sizes in literally 24 hours. Okay. It's edema. And so we manage it just like we would edema anywhere else. So ice, ibuprofen, scheduled ibuprofen, lymphatic massage, which is not like really firm, vigorous massage. It's like very light, feather-like massage towards your armpits, so towards your lymphatic system, to try to soften those breasts, because this can make it really hard for baby to latch on. You can imagine trying to suckle onto a rock. It's not that easy. Yeah. So they probably won't let you push that hard, to be honest with you, because it's really painful. I'm just saying, yeah, don't try too hard. It's a good question. Yeah, no, it's a good question. I think I would say you may get a little bit of pitting, but again, I'd really say it's just going to be more firm, indurated feeling. Usually symmetrical around the whole breast, symmetrical to both breasts, which is really key in learning that this is not mastitis, this is not infection, this is normal for this person. The cabbage leaves is interesting. So you store like cabbage leaves literally in the freezer and just like slip them into your bra. They've done some research to decide if there's anything like chemically in the cabbage that's helpful here. And it sounds like no, it's really just like a very cheap, nicely shaped ice pack that doesn't give like a lot of pressure and doesn't take up a lot of room in your bra. So cabbage leaves, it's like 70 cents for a head of cabbage or something, as opposed to like $20 for a box of like Medela little reusable flour icy things. Stupid. So just use a cabbage leaf. But again, do not tell them to pump more. The answer is feed the baby on demand. So whenever baby is signaling you think they might be hungry, feed them. If you're exclusively pumping, if for some reason baby won't latch, baby's in the NICU and can't latch, baby has a cleft palate and is not able to breastfeed until they end up having surgery, they should have a really clear pumping schedule. So pump every 3 hours. Do not pump more than that. There's no reason you are not helping, you are hurting. Because again, supply and demand, if you start pumping twice as often as you were before, your body thinks, maybe there are 2 babies, and it's going to start making a ton more milk, which puts you at risk for bad things happening down the line. So significantly increased chance of mastitis, really complicated for the mom to try to down-regulate that supply later on. So engorgement. Clogged duct for the mom. So this can look like a little teeny pimple on the nipple. It's usually white because there's some milk underneath it. No real surrounding erythema, no changes to the rest of the breast. It's just this little pimple on the nipple itself. Can be really painful. You can start to feel some pain kind of back, if you imagine, along that duct into the deeper breast tissue itself as the milk kind of like gets stuck there. So number one, don't poke it. I know we all want to poke the things. Okay, the breast is like the pancreas. Don't touch it. Like just leave it alone. When you get in there in surgery, like you're gonna screw this up. So that's my one of my biggest take home points for you guys is like, we always talk about like don't incise breasts in general. Really don't incise breastfeeding mom breasts. Like, just don't do it. So for these, rather than unroofing, this is another common term. So you take just like a needle and scrape the skin off and think, oh, perfect, I've relieved the blockage, everything's gonna drain out. Now they think that actually causes more damage down the line. You get a little bit of scar tissue there. Those ducts are teeny tiny. When they get stenotic, you're just setting them up for downstream continued clogs, worsened chance of mastitis, chronic mastitis. That's not bacterial. So again, same types of things: lymphatic massage, feeding the baby. Don't feed them extra, just feed them like you normally do. Ice the area. If you get these recurrently, a lot of women will start taking supplements, sunflower, lecithin, lecithin. I don't know exactly how you say it. I've heard it both ways. Just these capsules that they'll take like gargantuan amounts of per day. The thought is that it kind of thins out the breast milk a little bit, and so it's less likely to clog up inside of a duct. But that's more of a chronic thing. That's not going to fix it right this minute. The last thing you can think about doing, again, thinking that this is an inflammatory based process, is a little bit of steroid cream right at the clogged duct. So a little just triamcinolone cream, really mild steroid. They can wipe it off before they feed baby if they want to, but it's going to be fine if they forget one time. It's not going to hurt baby to have this little bit of steroid cream on there. So try not to touch it. Like, you don't pop pimples on your face. Don't pop a pimple on your nipple. So let me get to the good stuff. This is like what we all learn about as ER docs with breastfeeding, right? It's mastitis. It's like all we're going to learn about. And it's interesting because like the thoughts behind mastitis have really sort of changed over the last, I would say even just 2 to 3 years since I've been paying attention to this. Initially, what I was taught is like, oh, this is an infection. You have to treat it with antibiotics. You got to get the infection out. Now, again, what they think of is this is mostly an inflammatory process. So you have some inflammation along the ducts, around the lobules. Milk does kind of get stuck there, but a lot of the like erythema and induration is more inflammation and less infection based. So symptoms of mastitis, so most common like postpartum fever cause. So you see a woman in the first 3 to 4 months after they deliver with a fever and not a lot of other symptoms, it's almost always going to be mastitis until proven otherwise. So make sure you do a good breast exam on all these people. They may be developing mastitis because they're trying to wean the baby and they're doing it too fast. They may be developing it because they went back to work and they're trying to figure out their pumping schedule compared to how they were feeding baby. There's like a million things that can put you kind of at risk for mastitis. Like I mentioned before, the biggest risk factor though is hyperlactation. So making more milk than you really need for baby sets you up for this happening. So as with pretty much everything that's going on with the breast, you can still feed the baby. So don't tell them to stop feeding the baby on that side. Don't tell them they have to pump on that side. Don't tell them they have to throw that milk away. The milk is totally fine. Baby's stomach is not a dandelion, so they can eat that milk and they're going to be totally fine. Feeding or removing milk from the breast is key to kind of getting this to resolve. But just like everything else, don't tell them to pump extra. Don't tell them to feed extra. Just tell them to do what they've been doing. Because again, if you worsen how much milk they're making, this is going to take a lot longer to improve. Like I said, don't poke the boob. I don't care like if you think you see a really juicy fluctuant area on the breast and you put an ultrasound on it and there's tons of fluid there, please don't poke it. If you ultrasound a breastfeeding breast, there's fluid everywhere because hello, it's full of fluid, it's full of milk. So ultrasounds are not that helpful, I think, in our wheelhouse for deciding, do I poke this or do I not poke this? Because again, you're probably going to see fluid no matter what. There are reasons why a breast surgeon would want to IND an abscess. There are times where they need to put a drain in, but I am going to be hardline about this, that is not something that we should be doing, even if you think you know a lot about breastfeeding. They need a breast surgeon to figure that out. I would also discourage, like, if you call radiology about, can I get an ultrasound here? Could you do an ultrasound guided drain? The answer is going to be like, yeah, I can do that. I can put a drain in. But should you? You don't know. They don't know. Like, yeah, there's fluid. I can get it. just like a surgeon, hammer and nail. But breast surgeon is really someone who's really familiar with breastfeeding should be the one making the decision about opening this up. Because you can get chronic milk fistulas where you're just going to leak milk, just like you do like colocutaneous fistulas, and you just leak like colon fluid, bowel sweat, gross. I don't want to leak breast milk literally constantly. That sucks. So just don't do it. In the first 24 hours of symptoms, even if you have systemic symptoms. So my personal mastitis experience, I went from feeling totally fine to literally 5 minutes later, the worst raggers I've ever had in my life, like so much pain head to toe, my teeth hurt, my toenails hurt, just like when you get the flu, you just feel absolutely awful. So it's very rapid onset. And I didn't actually realize that I had any breast pain, redness, like that was not on my radar at all. It just really came out. So asking the mom if they have any breast complaints is not enough. You have to do an exam. But systemic symptoms in the first 24 hours are often still inflammatory in nature, not truly infectious. So if you see someone in the first 24 hours of them having symptoms, you don't have to start them on antibiotics right away. They're going to trigger your sepsis alert criteria. They do not need to be admitted to the hospital with IV antibiotics. They don't need source control. They don't need all the stuff that we normally think about with infections. Because again, the first 24 hours is almost always inflammatory in nature and can be managed conservatively. So ice, ibuprofen, lymphatic massage, feed the baby, just like try to relax about it. Usually in those early stages, it's really like localized breast erythema, kind of like you see in this picture. So you can kind of imagine it following along a duct into a lobulated area. You can feel better about not doing antibiotics if it's more localized like that. Once their whole entire breast gets really red and you get more induration of the whole breast and the fever has gone on for 48, 72 hours, then it's probably worth your time to cover them with some antibiotics. Dicloxacillin is the easy kind of go-to one. In someone who's a first-time mastitis person, that's what I would choose. People can develop mastitis multiple times. Some people will just get it routinely and I feel really terribly for them. Different antibiotics, you can get breast milk cultures, you can talk about breast dysbiosis, which is like all kinds of abnormal stuff growing in your breast that's way above our kind of pay grade. I would say if they're having chronic mastitis, they need to see a lactation consultant or a breastfeeding medicine physician to figure out why that is. Do you have a question?
Yeah, so if you see that like this exam
Yeah.
here, you mentioned that might just be local inflammation that potentially could resolve on its own.
Yeah.
Are you ever considering like the idea of like a wait and see antibiotics where you're prescribing dicloxacillin to tell them to wait?
Yeah, you totally could. It's the same thing as doing it for ear infections in little kids. They're probably going to start taking it immediately, and you just accept that they may do that if that's what you do. But there are people where that may be a really reasonable thing to do. Just watch and see. If you're feeling any better, I would wait. Like I started feeling better. I was ill for like 8 hours. And then I don't know, I fed the baby and then I was like, oh my God, I feel awesome. And everything went away. I felt great. So it really is like on off. Yeah. Yeah.
Are you getting there?
No, I'm not getting there. Go ahead.
Isolated infection of breast.
In the first, again, 48 hours of symptoms, especially first time, no, not really. Because again, I think chances that you're going to IND an abscess are pretty low. Of course, you can think about people who are immunocompromised. So if they're on a bunch of biologics for their rheumatologic disease, okay, maybe I'm going to start treating earlier, just like I would with anything. I might drain an abscess and cover them with antibiotics anyway. I may admit them to the hospital for 24-hour OBS, make sure they start going the right direction. But for the most part, again, these people, I guarantee you, they will trigger your sepsis criteria. They're going to be tachycardic, they're going to be febrile, they're going to have a focal area that you're concerned about for infection. And I'm still going to argue that in the first 24 hours of symptoms, they don't even need antibiotics, let alone hospital admission, imaging, anything like that. Now, if this is something else you have to consider breastfeeding moms get breast cancer too. right? So if this is an area of indurated breast that has not responded to antibiotics, maybe they're not having the systemic symptoms as much anymore, those people need to be imaged, but not imaging for abscess, imaging for cancer. Which leads me to a point, I didn't make a slide about this, but this is my new pet peeve, is people, so breast like masses are not normal in breastfeeding. You shouldn't have like a focal, kind of fixed, like always present hard area of your breast. If that's the case, like they need to have a mammogram yesterday. Mammogram is the study of choice to diagnose breast cancer still in breastfeeding patients, also in pregnant patients. So don't ignore, a breast mass in a pregnant patient. Pregnancy-associated breast cancer has a much worse outcome than patients who get breast cancer when they're not pregnant because of the hormonal relationship. And also, I think, delayed diagnosis. So a lot of people will get told, oh, you can't have a mammogram when you're pregnant. Just wait until after you deliver. Oh, and then mammograms are hard to read when you're breastfeeding. So wait until 3 months after you've weaned. A lot of people breastfeed for 2+ years. So you can imagine, right, how bad their cancer is going to end up if they're waiting that long. So if you see a breast mass in a pregnant or a nursing patient that is not normal, you need to image that. So if there is like a true mass that you can feel, then I would image it. Yeah.
So let's say we're several days into it.
Yeah.
Just continue to have pain and redness.
Yeah.
Sounds like what you're saying is breast abscess is fairly uncommon.
So yeah, I'm trying to decide if I'm going to actually say that. Yeah.
Okay. So then let's say we're considering an abscess.
Yeah.
What would be your imaging choice? Let's say 3 or 4 days into it.
Yeah, I would still probably start with ultrasound because they can make some. So I said, I don't think we should hang our hats on ultrasound. If you're looking at it, you see simple fluid versus like a really heterogeneous, gross looking like a phlegmon kind of, that is more suggestive of, is there a true abscess in there? So you can make some comment about it. I just think you have to really know what you're looking at and be able to tell the difference between just normal milk collection, maybe a clogged duct where that lobule and duct are really swollen versus true abscess. That's a fine decision to make. And that takes a radiologist who knows what they're looking at also. So ultrasound would be my first choice if you're going to do anything. Yeah.
It sounds like regardless, I mean, even if the call is an actual breast abscess,
Yeah.
we're probably best off consulting.
Yeah, don't touch it. Yeah, make someone else decide what to do with it.
Don't touch the breast.
Yeah, don't do it. I'm really serious. Breast and pancreas, just don't do it. It shouldn't happen. Okay, good. Other questions about meds? Because again, this is probably the thing that you're going to see the most. So don't feed the baby extra. People will do all kinds of crazy things to try to make this better. I had a woman who was putting sliced potatoes in her bra, like something about the starch was supposed to like draw the milk out. I mean, it's probably not hurting anything, but definitely don't think it's helping. So people do all kinds of weird stuff. Don't be aggressively squeezing the breast. Don't be aggressively massaging the breast. Back when this happened to me, the recommendation was use some vibration. So like an electric toothbrush. So take an electric toothbrush and like let it vibrate around on the area of your breast that is painful, not on the nipple itself. But now they say probably don't do that because again, you're increasing stenosis of the duct, scarring in the duct. You're setting yourself up for this becoming more recurrent. So try to minimize the touching.
You mentioned
Yeah.
ice. Is there any place for heat or like?
So again, they used to, when this happened to me, it was heat in the first like 24 hours, try to like release the stuff. Now they think, again, it's inflammatory to begin with. So heat probably is not going to help and could potentially hurt.
It sounds like the whole shift in treatment was really identifying the true etiology of it. It sounds like initially the etiology was thought to be flow. Now we recognize it's not flow, it's inflammation.
Exactly. Yeah. Right. For whatever reason, that duct is inflamed and not allowing the milk to come out. So if you decrease that inflammation, things will happen. Good. Okay, a couple like baby things you may see. So parents will bring their babies in thinking there's something wrong. We already talked about the poop thing. Cluster feeding is a very common thing that will happen in the first few weeks of life. So I said you're emptying or you're removing milk up to 12 times a day. It can be like literally almost constant. There are moms that will come in and say, baby will want to stay latched for an hour. And then I take them off. 10 minutes later, they're crying again. They want to latch again. Is it because I'm not making enough milk? Is it because they're hungry? Should I supplement? Should I give them formula? What do I do? This can coincide with like the colic time, which now kind of new terminology for this is purple crying, not because they turn purple, although they might and you might from being angry, but purple. So persistent, unexpected, resistant to soothing. I forget what the second P is. E is evening. I forget what the P and the L are, but it's basically colic, right? Where the kids cry for no fucking reason, excuse me, for like 5 hours in the evening time, and nothing that you do makes it better, and just have to like put them down sometimes and walk away. This is now, they call it purple crying. The second P is pain. So they look like they're in pain, but they're not in pain. They're just like cranky, gaseous malcontents is what I've heard that age infant described as. Like they poop a lot, they make weird faces when they poop, they pass a lot of gas, it smells worse than your husband, and they cry all the time. And like, what's wrong with my baby? Like literally nothing is wrong with your baby. This is so
It's like
normal.
adolescence.
I know. Yeah, exactly. So it can coincide with purple crying, but it doesn't have to. The baby may just want to stay latched all the time. And mom is like, again, the question to you guys is, do I need to start supplementing? Do I need to add formula? What can I do to increase my milk supply? So this is where a lot of women will get in the pumping cycle where they think, oh, my supply is low. Let me pump a whole bunch to increase it. They start making enough for 2 babies, and then they start getting clogged ducts and mastitis and all kinds of problems. So this is normal. If they are gaining weight appropriately, they're pooping at some point, let it ride. Like reassurance is what you do for these people. Don't say, oh, well, you could add a bottle of formula. Oh, well, you could try to pump, an extra time during the middle of the night, because that's when your hormones are like most responsive. Just don't. That's not going to help, and it's going to potentially hurt down the line. Jaundice would be the other thing, right, that we all learn about this in med school. Breastfeeding jaundice, breast milk jaundice. So breastfeeding jaundice, first week of life, this is a supply intake problem potentially. Baby is not taking in enough for whatever reason. Maybe it's because they're not latching very well, they're not removing milk very well. It could be that mom has delayed lactogenesis too. For some reason, she had peripartum hemorrhage. She had a C-section, which is known to delay that. So her milk hasn't come in by day 3 or 4. That still can be okay. They can still have their milk come in, but baby will start getting jaundice. So you see a jaundice baby in that first little while who's breastfed. They're gonna need, phototherapy potentially, depending on what their level is. You can start talking about supplementing baby with donor milk is an option over formula. You can have mom pump and then supplement what she pumps. That's called triple feeding. So you let the baby latch, let them feed for as long as they want, take them off, pump for 15 minutes, see how much you get, and give the baby that if there's any extra. Doing that for just a couple of days at a time. I don't know that we should be making recommendations about supplementing this kid necessarily. I think this is still, what is your Billy level? Do you meet criteria for phototherapy? What is your pediatrician follow-up situation? Ask mom about how she's feeding baby. Are you bottle feeding at all? Are you doing only like latching? How often are you feeding? How long does baby stay latched? Is it painful? So trying to get a sense of like, is baby really taking in what you think they should be? And then breast milk jaundice is the delayed jaundice that they'll get a couple weeks in for reasons that nobody seems to understand exactly, where if you're breastfed baby, sometimes you just get jaundiced after a couple weeks of doing it. Your intake is fine, the supply is fine, there's nothing wrong with the milk. Maybe it inhibits the baby's ability to break down bilirubin. Again, nobody really knows exactly that's like the not so dangerous cause of jaundice. You have to rule out, of course, something like biliary atresia or another reason for a young child to be jaundiced. But if it's just breast milk jaundice, you can keep feeding through it. It's usually doesn't get to levels that are really problematic. And you should also keep feeding through breastfeeding jaundice. So encourage mom to put the baby to breast as often as possible if that's something that she wants to keep doing. That's not going to make this worse. Okay, way number 3 to just kill it in the ER and kill it in a bad way is forget to ask people if they're breastfeeding, or don't do anything to try to support the person who is breastfeeding in your ER. So, I've said this a billion times, 12 times in 24 hours is how many removals they need. If they sit in your ER for 8 hours, they can't just go that whole time without either pumping or feeding the baby. That's going to cause problems for them, either in setting them up for clogged ducts and mastitis, or down regulating their supply if they're admitted for like 2 days and nobody's asking them about pumping. If they don't do anything, their supply is going to start to really go down and may not be recoverable. So easy things when mom is in the ED, either as a patient or with a child or another family member who's a patient, just ask them, like, do you need a pump? We can get a hospital grade pump down from labor and delivery. Did you bring your own pump? Is the baby here with you? You can feed the baby if there's no contraindication. Do you need a place to store your milk? Like, just put it in a refrigerator. Did you bring, little bottles? In a pinch, sterile urine cups are great holders for breast milk. So easy thing you can give to them. There's also all kinds of hacks to like get them to fit on the flanges and stuff, so you can actually screw them right onto the breast pump. But another thing to think about is hydration and what the PO intake of the nursing person is. So breast milk production uses like 700 to 800 calories a day. So just sitting there, your body is burning 700 to 800 calories just making this milk. And again, you're putting out 24 to 30 ounces of fluid that I don't normally lose, right? So that's an additional fluid loss for me. So these people get dehydrated pretty quickly. They can get really nauseated and super hungry really fast. So just think about it. If mom is allowed to eat, let her eat. If she's not allowed to eat, make sure you're giving IV fluids to replace this fluid that she's losing, whether you want her to lose it or not. And this is the easiest thing that you can do. WHO recommends now breastfeeding up to 2 years or longer if mom and baby want to. So don't think, oh, she has a 15-month-old, there's no way that she's breastfeeding, I'm not going to ask. Chances are that she is still breastfeeding and may need one or all of these things to help her while she's there. Yeah. Oh, this is my picture of the duct shower. So that's what it looks like. That's called hand expressing, which you can do in a pinch if you don't have access to a pump. Like I likened it to milking a cow, except with much shorter nipples. I've never milked a cow, but the videos, their udders look humongous. So don't pull on it. I'm not expecting you to learn how to do it, but that is what it looks like when you do it. You get just these like jets of breast milk, which I think is kind of cool. Okay. Now we're gonna get into our red and green cards. So this is, I think, the most common advice that's given by physicians who have no idea what they're talking about, right? They want to give a medicine and they're like, oh gosh, she's breastfeeding. I'll just tell her to throw it away. It's going to be fine. And then I can do whatever I want to do. I don't have to think very hard about this. And like, it's no big deal for them to just throw this milk away. Like, like I'm freaking out if I hear the words pump and dump because that advice is given so often. And if you have a mom who's like an exact producer, she throws out a pump, what is she supposed to feed her baby? Like if the kid has never had formula before, you don't have any extra in the freezer, like what is that 4-month-old eating? I don't know. It's kind of a big deal to think about it. And breastfeeding obviously is like kind of a full-time job in addition to whatever it is you're doing otherwise. And so moms will spend a gigantic amount of mental and physical energy around this. And if you tell them to like, oh, just do all this hard work and throw it away, it is like soul crushing to hear that. Like I did something wrong. I don't want to throw this milk away. I'm just not going to do whatever it is that I'm being recommended to do. I'm not going to take this medicine. I don't want to, have this medical intervention. I can't do it. So there's like a lot of emotions and expectations and stuff wrapped up in breastfeeding. So just like throwing out like, oh, whatever, just pump and dump for 1 day, 1 week, how long do you tell them to do it? There's like no science behind this. So we're going to go through a bunch of medications and things that we would commonly use in the hospital. I want you guys to tell me if green, they can go ahead and breastfeed with this medicine, or red, they cannot. Okay. And this is only good if people participate.
This is one of those moments where I really, really enjoy my attending.
Yeah. Oh, there's extra cards up here.
Exactly. This is for you guys.
You guys can totally take cards if you want to. Some of these are tricky. Some of these are not what you would expect. Okay. So we'll start with just a colloquial one. Alcohol. Can you drink and breastfeed? Can the mom drink and then breastfeed? Good. So this is totally fine. Those breast milk test strips are a complete sham. So if you think about this, BAC, blood alcohol concentration, equals the concentration of your breast milk. We think it does pass very easily from your blood into your breast milk. So let's do the math. If your BAC is 0.08, so legal limit for driving, your breast milk alcohol concentration is 0.08%. To put that in perspective, if you test most orange juices, they're about 0.5% alcohol. So it's different than when you're pregnant. Your blood alcohol is baby's blood alcohol level, right? That's why you're not supposed to drink when you're pregnant. You're supposed to think about it before you do it. But with breastfeeding, this baby is getting like less alcohol intake almost than water if you have any alcohol in your system. So the adage is, if you can find the baby, you can feed the baby. If you're too intoxicated to like sit upright and hold the baby, then like it's not safe for other reasons. Your blood alcohol is still probably not 0.5 unless this is a regular thing for you. And so you're still probably not going to hurt the baby from the alcohol content of your milk. You're going to hurt the baby because you're going to squish it or drop it or, forget that it's real and try to whip it around. I don't know, like who knows what you're going to do. That's why you aren't supposed to feed the baby if you're super, super, super drunk. But otherwise, like drink while you're feeding the baby. Nobody cares. It's totally okay. Just let it go. Now, of course, you can make your own choices about whether you drink at all or not. That's fine. But from a baby injury standpoint, this is not going to hurt them. So it's okay. If you have a beer at Christmas dinner, feed the baby. It's fine. Ibuprofen. Good. We should have all greens because I talked about this in all of the treatments for mastitis and engorgement and everything. So again, pregnant, we don't do it. Once baby is ex utero, ibuprofen is totally fine, even if it gets into the milk. Nobody cares. Pseudoephedrine, so Sudafed. Yeah, so people who think it's no, why? Yeah, good, exactly. So this is not actually dangerous for the baby from a medicine standpoint. If it gets into your breast milk and baby ingests it, nobody cares. But this is one of the drugs that they use actually to cease lactation. So if a mom needs to cease lactation for she has a breast mass and needs surgery or needs to go on a medication that truly is contraindicated, Sudafed is how you stop it, like the easiest way to stop it. And this is a 1 dose and it's over. So this is not like it's going to take a week. This can be truly 1 dose and your supply is irrecoverably gone.
Yes, I definitely knew that.
Yeah, I didn't know this until I was breastfeeding, but this is a big deal. And the further along they are in their breastfeeding journey, the more likely it is that 1 dose is going to do them in. So if they have a 10-month-old, very likely that their supply will just completely disappear. If they have a 6-week-old, it's going to take a big hit, but they may be able to get some of it back. So the earlier is maybe less dangerous, but still do not do it. This is a hard no in breastfeeding. Antihistamines. So, right, everybody comes in with snotty noses and they all want something to fix their allergy symptoms, whatever, this time of year. Yeah. So most of the yeses, I'll say this is just a caution medication. Again, not dangerous for baby, but some women can be really sensitive to antihistamines with their supply. More common with something like Benadryl than like a Zyrtec or Claritin or like a more selective H2 blocker. So just let them know that this could happen and they can make the decision about whether they want to try it or not. If they have oversupply, they may be like, oh, thank God, that would be great. I'll go ahead and take this. And if it decreases my supply, that's perfect. If it's somebody who's already supplementing with formula, who's had a really rocky road, like they probably are not going to take it because it's not worth it to them. So just let them know that it can happen, but not dangerous for baby at all. Pepto. Why? Yeah, I know a lot of these could be greens. So just something to think about. Remember, Pepto is salicylate, so it's aspirin. So baby is going to get some of that. This does cross into the breast milk. In a baby who's well appearing, who's not having any symptoms of a viral illness, they're probably going to be okay. They tend to tell people, they being like breastfeeding medicine physicians, tend to tell people to avoid it if they can. One dose is not a reason you should interrupt your breastfeeding. If you forget about it and take a dose and then you're like, oh crap, I forgot. Feed the baby, it's okay, but not something you want to be taking for days and days and days. And if baby is ill, then Rise syndrome, which like I've never seen. I don't have any of you ever seen this. Yeah, it's interesting.
Of course I've seen it.
Exactly, right. Yeah, one of those things that like we talk about a lot, but damn, I'll miss it for sure if that's what somebody comes in with.
Big thing with ladies.
Yeah, I know. And yeah, I've definitely never seen it. But that's the concern is I'm just saying, I have not seen it.
So
I kind of
your last lecture.
I know. I know, sorry. But again, well, baby, Rise is not going to happen to them. This is only in kids who have a concurrent viral illness. Opiates. Yeah, it's totally fine. Guys, what do we give people post C-section? Right, we're gonna give them Percocet, we're gonna give them oxycodone, they might go home on PO Dilaudid. There's like all kinds of opiates. We use opiates during labor where a baby is getting a ton more than they would ever get from breast milk, right? Because they're getting it direct IV blood flows. So opiates are okay. You do not have to pump and dump with opiates. You can treat people's pain with opiates. If they are awake enough to hold the baby, they can feed the baby. I will caveat all of these medications. Lots to think about if baby is like a 29-weeker in the NICU and mom is pumping milk for them to give to the baby later. Those patients should have a lactation consultant that they're already working with that can help you with medications because they're going to be substantially more conservative with a 29-weeker who's still in the hospital. Not saying it probably will hurt them, but they're like this big, you know? So dosing is different for them. It's going to be a lot more of a problem for this big baby than a this big baby. So just a caveat, if the baby is still in the NICU, then you're going to need some help as an ER doc. Don't try to do that on your own. Figure out if something is safe. CT contrast. Mom comes in, has some flank pain, fever, you think pyelo. Excellent. Yeah, this is totally fine. You don't need to pump and dump after CT or MRI contrast. You don't need to delay feeding after CT or MRI contrast. Feed the baby. Ooh. So you do a HIDA in the ED or you do a VQ scan, you have some radioactive dye that's given. Yeah, this is a tricky one. So we got to pause for this one. It is going to get into the breast milk. Their breast milk is going to be a little radioactive for a while. So you have a few choices and it depends on exactly what the tracer is that they're using. So you got to know, because like Tech 99 is not what they use for everything. Different hospitals may use different things. So you need to know exactly what radio tracer they use. But the idea is you can pump depending how long you have to pump for depends on what they're using, and then let the milk sit far away from the baby for a couple days, and then you can feed it later. So pull out of your freezer stash for, the 8 hours that you're pumping or the 12 hours that you're pumping if you have freezer stash. You don't have to throw the milk away, but you can't feed it right away. You got to let that radioactive tracer decompose according to its half-life. So it's a weird one. That's the only like radiologic thing that you need to really be concerned about. Yeah.
That's pretty cool.
Great question. I don't know the answer to that. I don't know. I can try to look it up. I haven't thought about it.
I'm almost certain that it doesn't.
It shouldn't.
That's
yeah.
not the reason for time in the millions and millions of years. Is that
Exactly.
Fair enough.
Half-life,
Fair
yeah,
point.
It shouldn't affect it. Yeah.
All right. The crowd has spoken. Freeze away.
That's going to be an interesting conversation.
I know.
to have with
Yeah,
Mom.
exactly.
Yeah, what
Yeah, let the milk decay a little
It's
bit.
not good
Yeah.
right now,
Just let it go.
but as it becomes less radioactive,
Then you can feed the baby. It's gonna be
It's still blowing in the
do
refrigerator.
not
Yeah.
give that woman the press games.
I know. Yeah. Right. Nice. Okay, so I'll just globally say sedatives, so the ones that we would use in the ED for a procedural sedation or an intubation, potentially propofol, ketamine, Haldol. Yeah, once they're awake enough, they can feed the baby. So they don't need to pump any at all. So after they get the sedative, it's not like you got to pump that milk out and you can feed again later. By the time their body has metabolized it, you're good to go. So awake enough to hold the baby, you can feed the baby. This gets tricky if you did intubate this person, if they're going to an ICU, right? They are really ill and they're going to be on a sedative for a long period of time. It's a little bit dose dependent. It depends on which sedative they're using. That mom will need to be pumped when she's in the ICU. So something else you guys can think about when you're on off-service rotations, you have a lactating mom in the ICU, they need a pump also if they want to continue breastfeeding, and keep in mind things like mastitis can develop for them. So that is a little bit of a nuanced question that you should talk to the lactation consultant in the hospital for. But one-time doses like we do most often in the ED are fine to feed the baby. And once mom is extubated and awake, once she's awake, she can feed the baby. It doesn't matter how long she was on this stuff or what doses she was on at that point. When you're awake, you're good to go. Anticoagulants. So postpartum mom gets diagnosed with PE or DVT, you got to start her on something. Yeah, this should be so easy, but it's not. It's really weird. Warfarin, good to go. No particular things you need to worry about. These NOACs get a little funny because there's obviously not a lot of data for them because they haven't been around that long and nobody wants to test this on pregnant or breastfeeding patients. But they do know that Eliquis in particular readily crosses into breast milk. So baby can start getting some anticoagulation, but it also significantly decreases serum concentration for mom. It like hyperbinds in the breast milk. And so mom's concentration goes down. So she's not protected with the Eliquis dose that you think she should be on. So this is one where you need to look it up, definite case by case basis. Don't just think, oh, it's anticoagulant, it's just for mom, it's going to be fine. It may not be fine. And it may be a discussion with like hematology potentially, depending on what the situation is and how complicated you want to make it. Doxy, it's a common one we talk about, right? Teeth staining in pregnancy. Yeah, you're fine. In a lactating patient.
More recent studies actually
Exactly.
suggest that it's really okay for
It's
kids,
okay.
period.
Yep.
Like to, as a treatment.
So less than 2 week course, absolutely fine in pregnancy, in children, and also in breastfeeding moms. So treat the Lyme. Methotrexate. So we would use this, right, for ectopic in the ED. So we're talking one-time dose, not, putting someone on it for lupus or something. Yeah, so you guys are right. This is something that we would suggest pumping and dumping for 24 hours, so half-life. To be fair, there is some controversy around this in like breastfeeding positions that a single dose you can probably feed through. It's probably going to be okay. So I guess risk benefit conversation with the mom. Good luck finding a ton of data to back you up. There are a lot of people who will say, no, you don't have to interrupt for single dose, but this is one where I would probably still tell them you should pump and dump, and not something you can be on long term for breastfeeding. Just a few more. Fluorescein, this one was asked to me particularly by one of my residents because they tried to order it on a patient who was lactating and the little thing popped up saying that they can't do it. So fluorescein stain for foreign body. Yeah, that's fine. What's not fine is like fluorescein angiograms like they'll do in ophthalmology clinic. IV fluorescein is like a little bit of a more complicated question, but how we would use it, put it in their eye, it's fine. Pretty much anything you put in people's eyes or on their skin in breastfeeding is totally fine. Prednisone, they have back pain, they have an asthma exacerbation, they have whatever. Why do we have so many reds? I'm very surprised. Why? Yeah, good. Again, so this can affect their supply. This is usually a transient effect. After they come off of it, they can get their supply back. So we want to avoid prolonged courses because it makes it less likely they're going to be able to recover. But it's again, not really about the baby here. It's more about supply. So just something for them to be aware of.
Fine for long, like more than 5 days.
Yeah, I would say like if you're going to put them on a long taper, like a 2-week taper or more, they're going to have a tough time probably. Good. So in summary, right, very few of these things that we do actually require interruption in breastfeeding, pumping and dumping, alternative nutrition sources. So the big take-home ones that I like to have just as a top of my mind, methotrexate, radioactive contrast media, Tessalon pearls, just because in general, Tessalon is like dangerous for kids, right? It's one pill can kill. If a 2-year-old gets a Tessalon pearl, they're going to have a lot of respiratory depression and have a lot of issues. So this can have some metabolite that is not good for a kid, but in general, I think a lot of breastfeeding people are very conservative about prescribing Tessalon because they don't want it in the house where the kid could get a hold of, like actually get a hold of it. Codeine is a metabolite issue, so don't give codeine to a breastfeeding mom because that is going to be a problem for the baby. Eliquis, as we mentioned, Bentyl, also a metabolite issue. And then the supply affecting meds that we talked about, Sudafed, some antihistamines, steroids to a point. The opposite effect with Reglan. So this is a medication they use as a galactagogue, so to help moms increase their breast milk supply. Less likely to be a thing from a single dose, but if you send someone home on Reglan for some reason, they may notice a significant increase in their supply, whether they really want it or not. So if you remember nothing else, this is kind of where I would recommend you look things up. So again, don't say anything that isn't actually evidence-based. There's a lot of evidence out there for this, or a lot of protocols to sort of guide you. Don't just make it up as you go along. Some basics, so Kelly Mom is a website that has a ton of just very written like for lay people, basic information about breastfeeding, common questions. So something good for you and for the parents to look at. Common complications, the Academy of Breastfeeding Medicine has a bunch of protocols about treatment. So they have a mastitis protocol that's like 15 pages long, but the actual recommendation is like 2 paragraphs. So that's where I would go for the most up-to-date treatment recommendations. Don't go to up-to-date. Up-to-date is actually like crap for most breastfeeding information, including medication safety. So if you look up a med on up-to-date, it's almost always going to be like unknown if compatible. And that's all it will say. It doesn't give you anything. So the 2 places I recommend you look when you're trying to decide if the medication is safe. There's an app that's called Infant Risk. It's $10, just one-time download, and then it auto updates forever. So that's the best app. LactMed is run by the NIH. It's a website only. It used to come in an app form. I don't know if anybody has it. You can't download the app anymore, and the app doesn't auto refresh. So if you have it on your phone, you can still use it. Just new meds may not be on there. But it is a website. So if you just Google like LactMed ibuprofen, it'll come up with the site, and it will tell you, yeah, it might be category C because we have no data, but here's what we know about the pharmacokinetics of this, the molecule size, how much we think gets in breast milk, like the animal studies that are available. It's really quite digestible. So those are the two places I would look to decide about medication safety. Infant risk also talks about pregnancy safety, and LactMed I think does, but LactMed is more focused on lactation. And then make sure that mom can pump or feed the baby while they're in the ED, like a really easy thing that you can do. Just recognize that someone might be breastfeeding and do they need any support while they're in the ED. That's it. Questions that you guys haven't already asked me. I should have said at the beginning, this should be like super informal and I'm going to tell you a lot of stories about myself. Sorry, I didn't prep you. Yes.
Since you made fun of my rice thing.
No, I wasn't making fun of you.
I'm going to back it up a little bit in the pregnancy. So a big
Yeah.
thing that I saw controversial was in pregnant women, a VQ scan versus CT scan.
Mhm.
And we,
Yeah.
if you look at literature, it's all like which one has
all over
the
the place,
most
yeah.
radiation exposure to fetus.
Mhm.
One of the discussions we had with our radiologist was that the CT obviously was easier, gave you more information,
Yeah.
but it was a huge, well, not huge, but a significant radiation dose
Yeah.
to the developing breast.
Correct.
And the concern was, would that place women at risk for breast cancer later?
Yeah.
Would it increase risk? So, do you have any opinions?
I don't have any more insight than that at this point. We have the same discussion. Our radiologists tend to recommend CT over VQ scan. I think because it's a better study, right? You're more likely to get an answer than a VQ, which is always indeterminate. I hate VQ scans. But yeah, that is the thing to consider. And again, I have no additional thoughts about it other than what you already said. I think I have the same struggle.
Yeah, for a while, we went half perfusion only, half dose
Mm.
to really limit it.
Mhm.
I mean, that's kind of after a lot
MacGyvering it a little bit, yeah.
Test X-ray.
Mhm. Yeah.
Then you're more likely to get an answer on a perfusion
Yeah.
scan as opposed to if they had an underlying lung disease.
Right. That makes sense. Yeah. Yeah. Our shop tends towards CTs, but that is the risk to discuss with them is
I don't
breast
think anybody
radiation.
knows, really.
Yeah. I don't think anybody knows. I agree with you. Anything else?
Well, thank you very much. I'm
You're
going to
very
spend like the
welcome.
next hour thinking about all the breastfeeding mothers that I've wrecked over
Yeah,
my
me
20
too.
years of practice.
Now you know differently, do differently. That's all I'll say. I said all kinds of stuff before I was a parent, but now I'm like, what was I thinking? Thank you guys.
Oh yeah.
Yeah.
Yeah, absolutely.
That was excellent. Very good. It's a topic when